Good afternoon, ladies and gentlemen, all the colorectal colleagues here. Instead of saying thank you at the end, let me thank everyone, the organizers, the chairpersons, and the audience who is waiting very patiently. I have requested Dr. Kushal to stay back because he wanted to understand. When I was asked to speak something in this particular meeting, I said, let me have a topic called why do fistulas recur? But it was that it has to be combined with something in a recurrent fistula. So how to manage? But since morning, we have had every type of fistula described, the anatomy described, the what to do if a fistula fails, if what to do with laser failure, everything has been described. So there is nothing new that I am going to say, like incomplete removal, improper procedure selection, inexperience of surgeon, nothing like that. Let me go to the main reason for what I want to present to you all today. The failure during the operation, Dr. Kushal has very clearly mentioned that probing can cause an internal opening to occur rather than be found out. So workup and management is the same as that fistula. In one line, what causes fistula causes its recurrence also. So let us know what causes fistula to begin with. We all know there are in the cryptoglandular type of fistula, there are glands which get infected, become collect pus, and the pus goes here, there, everywhere. And what you can do, you have to tackle the gland. From the days of Dr. P.N. Joshi and all his disciples, some of them are sitting here also, we have been told, remove the gland, rest everything will take care of itself. Yes, if there are abscesses, drain, all that kind of thing needs to be done. So what is the role? Because in the anal canal, apart from the skin outside and the mucosa inside, what is there? Only sphincters. And we talk about save the sphincters. All surgeries are sphincter saving surgeries. But what do the sphincters do? Are they playing any role in causation or progress of the disease itself? And we have made no attempt to clarify, even today, why the fistula developed in the first place and why the gland got infected. The gland is there like tonsil in the throat, it gets infected. But why? And at 6 o'clock, most often, sometimes 12 o'clock. But most of the videos and pictures that are shown are going from the lateral 5 o'clock with an internal opening being shown at 3 o'clock. You don't deal with the 3 o'clock one in the same way as the 6 o'clock one. And this is a picture which has been shown very often. Today must have been there for about 4 or 5 times. Everyone sees that there is a opening outside and that there is a internal opening or gland infection. But the tracts are going up and the tracts are going down and the tracts are going laterally. Why? What is pushing this pus up, down, laterally, around, everywhere? Why can't it be that the pus could have formed in that gland and drained inside the rectum and there would have been no problem at all? All the surgeons sitting here would have missed all the BMWs and Mercedes that they drive. But it does not happen. So today I'm going to talk about why this particular thing happens, what to do in a fistula, what to do if it recurs again. There are so many things. There are hundreds of procedures which have been told to you since morning. So no use of my repeating all that. This again is a very important space description where all the pus goes. The tracks are known. You know that there is a road going from here to Connaught Place to Ridge Road to Dholakua. But why does the pus go along those? And this is again the same thing. What pushes the pus? I have been studying the cause of anorectal disease rather than going into the details of how many things can be done about it. And one of the techniques or in my armamentarium is anorectal manometry, because what is seen here since morning are anatomical structures. There is a gland, there is a muscle, there are spaces, pus going here, pus going there, drain from here, drain from there. But what is the pathophysiology? Why that gland got infected? In the anorectal manometry, we see the function of the sphincters rather than just that there is an internal sphincter, external sphincter with 4 different parts. The initial manometric experience we had, we could only find high pressure, low pressure, normal pressure. And at that time, it was only for fissure. So we said high pressure fissure, low pressure fissure. But as we progressed and found out that something more can be done, then we could now find RAIR, levels of urge up to discomfort, balloon expulsion was added to it. That finalizes the presence or absence of a thing called dyssynergia. The reason why pus is moving all around is because of this dyssynergia. The sphincter which pushes the pus up into the levator ani and supralevator is because it is not allowing it to come down. The pressure is coming from inside. When you are straining, when the stool is being passed, it goes laterally. Down below is closed, it goes up. Like water or any liquid, it will find a way of going to the path of least resistance. And that is why collections happen all over the place. If we do not have dyssynergia, probably the gland will only be infected and then kill itself, and no abscess will form. Dyssynergic dissification is the underlying pathology of formation of all anorectal diseases, including fistula and the recurrence about which I am talking about. In here, as I told you, there is a discoordination between the force coming from above of the pressure to pass the stool and the relaxation of the sphincter which should occur to allow it to pass, which is not happening. The sphincter goes into spasm or closure, and the more often it happens, fibrosis occurs. Most of the videos and pictures that you have seen today, the surgeon is able to pass the split anoscope inside to see the internal opening and to find out what the mucosa looks like. But when a recurrent fistula comes to me, all I can do is pass one finger. Even in the OT, I cannot go inside. So I use the old metal retractor in order to go and find out whatever it is. The machine you have seen, I'll just explain very briefly what are the patterns of dyssynergia so that we understand what we are dealing with. This is the normal pattern, where there is increase in the pressure above and a decrease in the sphincter tone. So that relaxation and this pressure increase allows normal movement of stool. In type 1 dyssynergia, there is increase in the pressure, but the muscle of the sphincter, instead of relaxing, also contracts. So it closes that opening below, the pressure increases and pushes the pus on all sides. In type 2, the pressure is low. patient does not have enough pressure in the rectum, but the contraction of the sphincter is there whenever he tries to pass stool using his abdominal muscles to push through, and again the same sort of disruption occurs. In type 3, this is a different one where there is enough pressure in the rectum, but the sphincter, instead of relaxing or contracting, just flutters around. And in type 4, there is no pressure above and there is only flutter and no relaxation above. These type 3 and type 4 are seen in prolapses. Type 1 and type 2, they are important from the surgical point of view. Type 1 is seen in fissure and fistula. Type 2 is seen in hemorrhoidal disease. Balloon expulsion test, in which a balloon is put into the anal canal and then inflated. The patient at 50 cc or 100 cc or 200 cc finds the urge and then discomfort, and at 50 cc he is asked to or she is asked to push the balloon out. If they are not able to do, then we get the picture of what is happening to the muscle, and that if there is a paradoxical contraction of the sphincter which should have relaxed, the balloon expulsion will be negative. If a patient is able to pass a balloon of 50 cc, it is a normal anorectal manometry. Now, this is the type of picture that we get in our hospital. The gastro people are able to do this on a very regular basis. The black means high pressure. The blue, green and yellow means low pressure. So here, instead of relaxation, you can see the black here also. Upper increase in pressure, increase in the sphincter pressure, and that is the type 1 which you get a response of. Now, what are the clinical implications of dyssynergia now that we know that there are 4 types? In type 1, as I told you, it indicates fissures or may even in the healing stage when the fissure is not painful. One of the caveats I have is don't get this particular test done when the patient is having a lot of pain, either of acute fissure, abscess or proctitis or whatever, because the patient will not be able to generate that pressure and relax. Treat conservatively, bring it down to a painless stage or a very good healing stage. You will still find the dyssynergia occurring. Type 2 dyssynergia with non-expulsion indicates piles with healed fissure. The recurrence of fissure leads to actual stenosis in the anal canal, and that is what recurrence of fistula also causes. Type 3 dyssynergia with non-expulsion, type 4 with non-expulsion, that is seen in cases of rectocele and prolapse, and we know by this that what we are dealing with as a case of constipation is not due to anything else but due to the ODS, obstructive defecatory syndrome, rectocele and pelvic floor. The whole of it can be involved. Dyssynergia is not localized to the anal sphincters. It is the whole pelvic floor which can have dyssynergia, and that explains a lot of patients who come with pain in the pelvis. So, very often we find patients who have had previous interventions in the form of office procedures. Somebody has put a thread in, somebody has put an injection there, or any kind of treatment, and we treat that patient for fistula, piles, fissure. We must know if there is dyssynergia. The gland which gets infected is because of the back pressure at the dentate line due to the dyssynergia, and like any gland where the duct has a pressure put on it, including the pancreas, where it is the back pressure into the duct which leads to pancreatitis. So all glands get infected because of back pressure, and the gland in the crypt also gets infected because of the back pressure. So if you have a fissure, don't wait and wait and wait. Do the treatment, get the dyssynergia out, he will not develop a fistula. If you wait, one day he will come back and say, now I have a boil next door to it, which we have seen so many times. This is the study which we did here as a pilot study of fistula only. I've done it in hemorrhoids, I've done it on normal volunteers everywhere. But here you see that anal manometry in first stage where the fistula presented to us. Out of 50 patients, 43 total cases, 86% of those had dyssynergia in 58 and were normal in 14. There, if we treat the fistula with whatever method we do, we get a good result. That is why all fistulas have good results. The recurrence is only from 5% to 60%, depending on who is presenting it. If it is Kushal who is presenting, only 5%. Others may have a higher. But where we had a second fistula or a recurrent fistula, here we see the patients that I did were 7, but the normal was only 1. And the dyssynergia was present in the rest 6. So, now we have a recurrent fistula. We have done the study for dyssynergia and we have found that there is dyssynergia. All the cases can be dealt with any form of treatment for fistula that you have learned here, with laser, with curettage only, with Ceton, with everything can be tried. But if you don't treat the dyssynergia, it will recur. So what is the treatment added for dyssynergia? Conservative treatment, that is relaxant ointments. Biofeedback therapy is very good, but in the presence of a fistula which needs to heal, biofeedback only treats or helps in the constipation part. And to that extent, post-operative healing of fistula is better. Botulinum toxin injection, not in the presence of fistula, only for fissure, that has been tried. Surgery, a form of sphincterotomy, is necessary to relax the sphincter and allow the elasticity of the anal canal to come back. Whether you do a lateral internal sphincterotomy, it is open or it is closed, and studies have shown mixed results with any of the treatment when adopted alone. So combine the two. When there are structural changes like piles, fissure, fistula, then you may not be able to do LIS separately, but add a sphincterotomy, like when you are removing the internal opening or the infected gland, you are actually cutting the internal sphincter. And not suturing it means you are allowing it to heal by secondary intention. There, if you put aceton, because what we do in lift, we just make an opening into the intersphincteric space. If there is a recurrence, it will be an intersphincteric fistula, which you can deal with either cutting it open or with aceton or whichever way. Now, these are all the recurrence rates which can occur in all the procedures that I have found out. It happens in years later. That has been also made very clear by the various speakers. So, in conclusion, recurrent fistula or early fistula, think of the cause, why it is happening. Planned surgery to avoid recurrence and treat recurrence should be done in stages and include planned Ceton sphincterotomies. Don't cut the whole sphincter in one, cut it in stages so that you don't have any incontinence. And we have had where we have had to do up to 6 or 7 in recurrent fistulas. With that, I come to the end of my presentation, telling you only keep your mind open for the cause and not go for the obliteration of the tract itself by laser or any other technique. Thank you.